Hello and thanks for watching Chunk and Check. We're continuing our paediatric series today by talking about some important conditions that present immediately after birth.
We'll cover 5 categories of these: prematurity, airway problems, neuro problems, feeding problems and jaundice, as well as the APGAR score. So first off, when a baby is born, its condition is assessed using the APGAR score. With a total of 10 points, the baby is scored on its appearance, pulse, grimace, activity and respiration.
Not just based on opinion though, you can't give them 10 because they're a cute one. The appearance category gives 2 points for a completely pink baby, 1 for blue extremities and 0 for completely blue and pale.
Pulse should be more than 100 beats per minute, so you get 2 points for that, 1 point if less than 100 and 0 if absent.
And then grimace or irritability as well.
Activity looks at muscle tone, 2 for limbs well flexed and active, 1 if a bit weak and 0 if completely limp.
Respiratory rate is automatically 2 points if there's a good cry. If there's a weak cry with irregular breathing, that's 1 and 0 if there's no breathing at all.
Don't worry if it's not a perfect 10, 7 or more is considered normal. A score of 4 to 6 means a baby needs some help breathing, giving it oxygen or a bit of suction, and 3 or less means you need to get on with some life-saving measures.
We'll quickly cover some definitions of prematurity now. So being premature means that you might need some extra help to get going, as you've not had a full chance to develop. And most of the conditions we'll talk about next are more common in the premature.
The normal gestation is 37 to 40 weeks. Any more than 42 is classed as post-maturity.
32 to 37 weeks is classed as moderate to late preterm, 28 to 32 weeks is very preterm, and less than 28 weeks is extremely preterm.
Weight-wise, the average is around 2.5 to 4 kilos. The lower the weight, the more support might be needed. Less than 2.5 is low birth weight, less than 1.5 is very low, and less than 1 is extremely low. And a birth weight under the 10th centile on a growth chart classes as small for gestational age.
Airway problems now. You might have identified a problem with the APGAR score, now you've got to work out what's wrong and know how to put it right.
Transient tachypnea of the newborn is the commonest cause of respiratory distress, and this usually presents within 4 hours of birth. It's more likely after a C-section due to the lack of trauma or shock squeezing the fluid out of the lungs. It takes a bit of time for this fluid to be reabsorbed, and it usually settles by itself and with a little bit of oxygen.
Respiratory distress syndrome is another one. This is surfactant deficiency, which if you remember is produced by type 2 pneumocytes. This is more common in the very preterm babies, less than 28 weeks, but rare after 32 weeks. The baby will have rapid respiratory rate, stridor and recession, with C-section being a risk factor again. Mum can have steroids before the baby is delivered to help develop a bit of surfactant, otherwise oxygen is given and surfactant can be given directly via an ET tube.
Meconium aspiration syndrome. In 20% of babies, meconium is passed before birth due to antenatal distress instead of just after. This is more common in late babies. If the meconium is aspirated, this irritates the lungs and leads to pneumonitis. This is quite an obvious one to spot, as you've got a floppy baby surrounded by meconium. To sort this one out, you need to have a good clean-up and suck it out. Maybe a bit of ventilation too.
So that was the airway. If you can't get the oxygen in, the brain can become damaged and you have a condition known as HIE or hypoxic ischemic encephalopathy. And this can lead to cerebral palsy in 30% of cases.
Some reasons for this occurring include placental gas exchange failure, umbilical blood flow interruption, inadequate maternal perfusion and failure to breathe. In mild cases, the baby will be irritable and have impaired feeding. In moderate cases, have tone and movement abnormalities, unable to feed and seizures, and in really severe cases there will be no spontaneous movement or any response to pain.
Let's move on to feeding troubles. So premature babies struggle to coordinate their suck reflex, and a lot of the time you'll need an NG tube which you can put the breast milk down. There might be a bigger problem than struggling to coordinate a feed, like an obstruction. This presents with vomiting as there's nowhere for the food to go once it goes in, and if the obstruction is below the ampulla vata, the vomit will be bile stained.
It's easy to think about obstruction by starting at the mouth and working down. Esophageal atresia is a congenital defect where the top of the esophagus doesn't join up to the lower esophagus and stomach. Most infants with this also have a tracheoesophageal fistula, where the esophagus connects to the windpipe, leading to air entering the stomach, which can be seen on X-ray.
Pyloric stenosis is a narrowing where the stomach joins to the small intestine due to a thickened muscle, and this leads to projectile vomiting, like proper projectile vomiting. If you did a blood gas, you'd find a metabolic hyponatremic, hypokalemic, hypochloremic alkalosis.
Which is basically a metabolic alkalosis with low sodium, potassium and chloride, right?
Yeah, that's right. So malrotation is another one, but this is quite rare. It presents in the first few days of life with bilious vomiting, peritonitis and shock, but they can be completely normal. Anatomy-wise, the duodenum is basically straight instead of C-shaped, and the mesentery isn't fixed. And this predisposes to it all getting tangled up and producing an obstructive volvulus.
Hirschsprung's is a condition that's commoner than students think. The nerves of the lower bowel don't form properly, so the bowel can't relax to allow the passage of stool. It's constantly constricted, giving a functional obstruction. And the telltale sign for this is a failure to pass meconium within 48 hours, if not within 24.
Down at the bottom of the tube, you might have an imperforate anus, where the tube just has a dead end. If you get your baby check done right, you'll pick this up straight away, so you can get the baby into theatre to open it up.
On another note, with maternal obesity and diabetes on the rise, baby might be born hypoglycemic, with a glucose level of less than 2.6. This can be due to more circulating insulin due to maternal obesity or diabetes, or a smaller glucose store due to prematurity or growth restriction, or even due to increased demand due to infection or hypothermia.
Quite easy to sort out though, give some dextrose to boost the sugars.
Lastly, we're going to talk about jaundice, and the best way to split it down is by when it happens. It's worth noting that infection-causing jaundice can happen at any point though, so always safety net to make sure you don't miss an important infection cause.
Jaundice within 24 hours of birth is always pathological and due to hemolysis increasing levels of bilirubin. Some causes include rhesus disease, but not if it's a first pregnancy. In rhesus disease, antibodies attack red blood cells when mum and baby are different rhesus groups. Anti-D is given in pregnancy to reduce these antibodies. ABO compatibility is another cause where IgG, anti-A or anti-B cross the placenta and break down red blood cells in the baby if its blood group is different to mum's.
You get a positive Coombs test in that one. It's also worth mentioning G6PD deficiency, where a lack of glutathione, which normally protects against oxidation, leads to hemolysis. This is X-linked, so the babies are always male.
Jaundice after 24 hours but before 2 weeks is usually normal. This happens as fetal haemoglobin is broken down and replaced by adult haemoglobin. Liver metabolism is also slower at birth, so there's an overload of unconjugated bilirubin giving the jaundiced appearance.
Jaundice that lasts longer than 2 weeks is due to biliary atresia or breast milk jaundice. Breast milk jaundice is poorly understood, but in biliary atresia, bilirubin can be conjugated in the liver, but can't go any further. As with any obstructive jaundice, you can get dark urine and pale stools.
You can't talk about paediatric jaundice without mentioning kernicterus. Unconjugated bilirubin can pass through the blood-brain barrier when the level is too high and cause brain damage. So it's essential that you identify the cause of jaundice and treat it ASAP.
So that's it. We've covered the APGAR score and how to notice when there's a problem, and we've looked at the most common issues that are immediately apparent after birth.
Hopefully that's helped you to be able to look at a newborn baby and keep a level head when everything doesn't go to plan. You've got to act quickly, so be aware of the conditions that we've discussed and keep them at the front of your mind next time you're working with neonates.
Thanks for watching Chunk and Check. We'll see you next time. Bye!